Bienvenidos.
Welcome.
Ya tenemos 500 participantes.
We already have 500 participants.
Hola a todos, bienvenidos.
Hello, everyone. A warm welcome.
Bienvenidos, bienvenidas a nuestro seminario web
Welcome
las Américas.
to our webinar on Hearts in the Americas.
Vamos a dar unas indicaciones para facilitar la
We're going to give you some housekeeping instructions. We would love for you to put your name and your country
en el chat, en su nombre,
in your profile name and also in the chat.
También les recordamos que va a haber interpretación
We would remind you that there's going to be simultaneous interpretation. So by clicking on the globe at the bottom and the lower part of Zoom, you'll be able to access the interpretation. Please use the chats to send us your comments, and we will have a recording of this webinar available after the event. And it will be available on YouTube. So without further ado, welcome to all of you. And I leave you with Dr. Pedro Ortuñez, who will kick off this webinar. Good welcome, Doctor. Thank you so much, Mariana. And good morning, good afternoon to all of you. Thank you for joining our webinar of Hearts in the Americas. We are celebrating World Hypertension Day. So I would like to be sure that those who are listening to the English channel are able to hear the translation. Could you please let us know if that is the case with a little emoji or a sign in the chat, but please just let us know that you are hearing the interpretation. And I'd love to know what countries you're from, so please also put that in the chat. So I can see a lot of thumbs up, but I would love to know what countries you're from too. Love to know where you're joining us from. I hope that we have representation from a lot of countries. I know that there's over 700 countries. And today I have the pleasure of being joined. I have the pleasure of joining this speaker as a session. And we also have with us Dr. Kenneth Connell from the UWI. He's president of the Caribbean Coalition. He's one of the most well-known people in the Caribbean. He's also an influencer. He's a natural communicator. So welcome, Ken. It is an honor to have a communicator such as yourself with us, and we're going to learn a lot from you. I know we're going to have a great session. So welcome, and I'd love you to greet the audience.
Good morning, good afternoon, good evening. Thank you so much, Pedro. There is no other place I would be this morning, besides probably Hypertension Clinic, than being on this webinar. I am really excited to be here. I know we've got a packed program, but it's so exciting. Interestingly, Hearts started 2 office doors down from my office where I'm standing here in Barbados as a pilot. So it's really, we've come full swing. We are here at this webinar to launch an exciting new product in Hearts. And I'm glad to see the representation from throughout Latin America and the Caribbean, but especially the Caribbean region. Shout out to everyone in the English and Spanish-speaking Caribbean. Thanks for joining us today. Happy World Hypertension Day. Over to you, Pedro.
Muy bien, Ken. Entonces, mira, tenemos ahora, estamos
Excellent, Ken. So we're just about to get going. Once everyone is connected, what I would ask everyone, I know that you have a lot of followers, Ken. I would ask you to comment on this and saying that the webinar for the World Hypertension Day is being held right now. This is similar to like a live event, and we have a really exciting surprise for you all today that we're going to be announcing. So you are all very privileged in this webinar because Professor Gianfranco Padati, if you could please turn your camera on, Professor. He is the president of the World Hypertension League, and he's going to make a very important announcement today. But before giving him the floor, we're going to give you a little clue of what's to come. What do you think, Ken? Shall we do that? Shall we give them a little clue of what's coming up
I think
so
we
that
should
our
give them a
friends can
small clue.
understand?
Yeah,
I
not
think
too much. A small clue. Go ahead, Pedro.
venga, adelante, por favor.
Okay, go for it. Let's show the video, please. Mariana? This happens on live television. The Dominican Republic is the first healthcare center to be launched in this country. This WHO initiative, which seeks to prevent and control NCDs such as hypertension and diabetes. The Dominican Republic was the first country to officialize the heart strategy in their country, a commitment. A mission. Lots of work. The word hearts not only means heart, it means a lot of things. It means habits and lifestyles. And to this evidence-based treatment protocols, I would add the importance of teams. Here we have access to medication and technology. Then we have risk-based management. Then we have team-based care. And finally, systems for monitoring, which I call follow-up.
El acceso a medicamentos y tecnología es esencial.
Access to medication and technology is fundamental to ensure that health centers are using appropriate and validated equipment, that they're well stocked in terms of medication, and that they are able to correctly control DVDs.
Los sistemas de supervisión y monitoreo son esenciales para...
Currently, the vigilance and monitoring systems are essential to measure the impact of these interventions and to ensure continual improvement. This gives us an opportunity to ensure that the interventions and strategies are effective and adapted to the population's needs.
Bueno, Ken, tenemos una pista ya, ¿correcto?
So
Ken?
we've given you a clue, is that right? Is that right, Ken? That was a
I think
clue.
we've given them a
Can you hear me,
small
Ken?
clue.
Okay, tenemos small clue. Entonces es hora de presentar al profesor Gianfranco Parati.
So Now we're going to introduce Professor Gianfranco Parati. So he had a technical issue, but if you are able to turn your mic on, that would be great. He is the president of the World Hypertension League, and we are honored to have you with us in this webinar.
I'm allowed to share my camera. Great. So thank you for the invitation. If you don't mind, I will share my screen. I have a few slides to show. And that's just to share with you the importance of this day. I hope you can see my slides. Okay, here we are. The World Hypertension Day is an important contribution to the race against the silent killer. You remember the WHO report published in 2023, where this was clearly stated. We need really to put more efforts in fighting hypertension. You know the numbers. 1.28 billion adults have hypertension, most of them in low and mid-income countries. 46% are unaware. Less than half are treated, and only 1 out of 5 are controlled. You understand how important it is to be organized in fighting this important problem. That's why it's still the major cause of premature death in the world. And WHO and WHL are working together. I'm very proud to be the current president of WHL because we want to work together with you in fighting this problem and improving not only the prevalence, but also the control of hypertension. You remember this colorful picture. The thick line refers to the prevalence of uncontrolled hypertension. The different colors refer to different regions of the world. And these are the Americas. Not so much different from the others. The huge prevalence of uncontrolled hypertension is still there. So we need to work together to improve the situation. And we have a lot of support by many people. HEART's program is one of the best examples on how we might fight hypertension and cardiovascular risk. And in your region of the world, you are having also some support from some countries. And I wish really to mention specifically what has been for us a great pleasure to give an award to a Minister of Health in Latin America that was really working actively in improving this situation. And this is Dr. Victor Elias Atala, the Minister of Health of the Dominican Republic. He was, with his country, doing a lot of work in implementing the HEARTS program, as you know very well, educating doctors, making these facilities available, including drugs, where they were needed at a population level. And that's a very good example for many other countries that if we work together, clinicians, researchers, and politicians, we may improve the situation very effectively. So let me just congratulate Dr. Atala for this important award. In the WHL board, we are so happy to have a politician helping us finally, and we want to continue this line. And I take this opportunity to thank you all for inviting me today. And also, I really want to continue working with you during my term in the next 3 years. One plan we have, as Pedro knows, is to organize the next World Congress on Hypertension in Latin America. So we'll be working together to build this because that will be a good opportunity to meet, to share our efforts, and to expand the knowledge on the importance of the condition to many other colleagues and people in the world. So thank you again for giving me these few minutes. I'm very happy for this possibility, and congratulations for the wonderful work you're doing with your organization in Latin America.
Profesor Gianfranco Parati, es un honor tremendo tenerlo.
Professor Gianfranco, it is an immense honor to have you with us. And I just want to say that we are ready to hold this Congress in our region. We are trying to put together a really great Congress. But today, since the person receiving the award is the Minister of Health, we want to say what a pleasure it is to have you with us here today. We have almost 1,000 participants in this webinar for World Hypertension Day. It's a huge, huge pleasure to receive Professor Gianfranco and to hear about this award that he is receiving. And we all wish to congratulate his country for this achievement. So well done on this great achievement. Thank you. It's our pleasure to be here on World Hypertension Day, celebrating World Hypertension Day, and to be able to do this with more than 1,000 participants who are participating in this webinar. On behalf of the government, the Dominican Republic, and the Public Health Ministry, we receive this award as an extreme honor on behalf of the World Hypertension League. We believe that this acknowledgement is one that shows what can be achieved when you have a president whose leadership is committed to this issue of cardiovascular health, and that's an essential pillar of our health system. I would also like to thank our international representatives in Washington and all those who have accompanied us in this process, which has really required a lot of work. So we're very proud of the work that's been carried out by our PHC teams, by the doctors, by health promoters, by the community leaders. They all wanted to make this possible, and they worked tirelessly to make sure that we could do continuous screening and treatment to effectively control hypertension in our beautiful country. This is also a merit of the Department of NCDs, who have managed to provide concrete scientific evidence to politicians and have these included in public policies using measurable results. So thank you so much for your commitment, which really has enabled us to expand our interventions to control hypertension, which is one of the leading causes of death globally. We know that this disease is one that is silent, but it has noisy, loud consequences that are devastating. So this award is, for us, a great honor, and it's a hope for every single person who receives a diagnosis, and also for every family who's living with this disease today. So we are going to aim for a health system which is more fair and which is centered on people, more equitable. So this acknowledgement, this prize, isn't a goal that's been achieved, but it's a starting point. We're going to continue strengthening our systems. We're going to continue innovating in terms of equity. We're going to continue to lead with responsibility, because we want to fight for a healthier population. And we are committed to that and to social justice. We want to continue expanding our vision. And I want to thank you from my heart for accompanying us on this vision. And I really, really wish that this Congress on hypertension in Latin America will be a success. We are at your disposal, and God willing, we will be able to continue working together in order to control this disease. This award is for all of us. So once again, thank you so much. Blessings.
Thank you very much. This is very exciting for us because you are a great leader. When we came to Dominican Republic, we saw one of its latest developments, which was the free delivery of medicine to a hypertension suffering and diabetes suffering patients who were not enjoying coverage, and not only coverage, but top-tier medication coverage. Dominicans are getting top-tier medications covered for treating their hypertension. We're talking about groups that have extended training to medicine and pharmacy schools. This is amazing. I would love to have more time, but one day you should speak to all of our colleagues and ministries about how you got the president of the Dominican Republic to set the implementation of hearts as the top priority to strengthen primary care, which I know is priority in your country. But again, I want to extend my heartfelt congratulations. It's not a PAHO award. It's a World Hypertension League award. So again, congratulations to you, to your team. I hope this also ripples across your country, because what you're doing is truly inspirational for our region. And I want to thank you to you and for Professor Parati for being here today on World Hypertension Day. We have a full Zoom hall. We have over 1,000 people. I think no one else can get in, but I want to tell you that this meeting is being recorded and it will be broadcast on YouTube very soon. I hope you can share this joy among other Dominicans so that they see their ministry in action. And I really hope we can keep on moving forward. Thank you once again, everyone, and we carry on with our program. All right, so Minister Gianfranco, thank you and congratulations. Ken, back over to you, right? Now we're going to introduce, in line with what's been served, I will ask a production to share the next slide. Let's see what is next. Ken, I'm going to
Pedro,
give you the floor because you are an expert on non-communicable diseases.
before you go to this
Yep.
slide, I want to personally congratulate the minister because, as we know, hearts is pulseless without political will, and strong political will especially. So I want to personally congratulate you. Countries that have been most successful with hearts and the implementation and expansion have all had strong political will. So thank you again. I look forward to your invitation to Dominican Republic and also to the Congress.
Pues Ken, aquí tenemos unos números.
Well, Ken, the numbers here are very interesting, right, to all of us, because they pave the way to what's next. What do you think of these numbers? Production, slide, please. Ken, I give you the floor.
Yeah, so these are very high numbers, Pedro, but they're not surprising to any of us living in Latin America or the Caribbean. The NCD burden is significant, and of course, it's driven by high blood pressure. On World Hypertension Day, then we also need to step back and think about the impact of this burden to those of us who are living in small island developing states with vulnerable economies and limited health budgets. In other words, we've got to get it right because we can't afford not to get it right. Every day, for instance, our emergency rooms are full of things like strokes and heart attacks and other cardiovascular events, and they clog health systems that are already saturated. We could also argue that some of this has been amplified in the post-COVID era. And so prevention is always going to be better than cure, but we also in the region need to address the social determinants of health as well as strengthening primary health care. And that's what Hearts is all about, Pedro, strengthening primary health care through the clinical pathway using evidence-based protocols and how you reduce these numbers so that we can improve the NCD care in the region and decrease the NCD burden. As I've always said before, and I know that the minister is on the call still, one of the previous prime ministers of Barbados said quite explicitly that the NCD burden has the potential of reversing all of the gains that we have made in Barbados and the region in our post-independent period. And that's significant. So these are important numbers.
Muy bien, Ken, pero fíjate tú lo que
Very
estamos.
well, Ken, but we're talking about this. I want people to do the math. We're talking about 9 million deaths in the Americas. 6 million die due to NCDs. Out of those, 2.1 million are from cardiovascular diseases. 1 every 4 deaths of NCD disease is heart-related disease. So when we're facing such a problem that cardiovascular diseases are the main killers, if you want to establish a program in your country and we say, okay, we want to reduce premature mortality rates, the question is, What are we doing? Are we taking consensuous steps? Because if not, then the answer is no, we're not getting close to the answer. But let's see what's behind uncontrolled hypertension. Over to you, Ken.
And look, and this is why it's so important, Pedro. Look at these numbers here. 58% of hemorrhagic stroke driven by uncontrolled blood pressure. 50% of ischemic stroke. Now, I'm right across the street from my tertiary hospital, and I know if I were to be in the ER now, that there are going to be a number of strokes there presenting patients who were either not diagnosed or diagnosed but not adequately treated. And of course, myocardial infarction, 55%. So these numbers really hammer home the importance of getting it right for hypertension.
Muy bien, quiere decir que la mitad
Exactly. This means that half of hemorrhagic and ischemic stroke and myocardial infarction, we need to understand that
veamos los números entonces. Ahora no vienen los números.
these are the leading causes of death. But let's see the numbers to see how severe this is. Let's see the next map. Production, please. Next slide. So we have 33 countries that are committed to implementing HARTs. 28 out of those are already implementing a high-quality clinical pathway. You say that we have to have a clear and standardized clinical pathway, because if we don't have it, then we're not taking the necessary steps. We see 33 countries are committed, not all. I'm sure that maybe some colleagues belong to countries who are not yet committed to HARTs, and then we have 28 countries that have a high-quality clinical pathway implemented, and we have more than 7,000 primary care centers. This is a huge number. This gives us at least 33 million people, but how many million people live in Latin America? How many people are off the grid? How many people are still using the same little prescriptions, and how many people are going undiagnosed and undertreated? Ken, I await your comment.
Yeah, so this is a challenge, and it's here in red right before us. Only 10 countries have implemented in over 80% of primary health care. Now, Pedro, this slide is an opportunity for us to congratulate ourselves, but also to remind us we still have a way to go, right? 10 countries out of 33 countries who have implemented HARTs have got it in 80%. So the coverage of in the primary health care. We really have to drive this program. We need to get countries who have already implemented to expand their coverage in country coverage so that we can get more primary healthcare sites using HARTs. This is a challenge. I know this is a challenge. But again, as I mentioned before, political will helps with this. Political will is the vehicle that allows HARTs to move seamlessly throughout a country. So it's very important. I just want to touch on the point you made, Pedro, about the importance of a standardized clinical pathway, right? No, so we've just survived, all of us here survived a major health turmoil, which is the COVID-19 pandemic. Having a standardized clinical pathway makes a difference, especially in emergencies, not just a pandemic. It could be a hurricane, it could be another natural disaster. If everyone is on the same page, including doctors, nurses, pharmacists, and patients, it's easy to follow. It's easy for us to continue care, even remotely. So I want to just put that plug in it there as well. A standardized clinical pathway is not just an advantage, it's really a necessity.
Muy bien, ¿qué? Pues entonces hablando.
Very well, Ken. Yeah. So along these lines, what are the game changers? I want to call people's attention here
I
because
don't see the game changers
Y
in your
que tú
contact.
también me ayudes en algún momento.
I want to see the chat. Let's see. Please
Let's look
write
at
down
the
the
chat.
countries that are
Unlock
here,
your iPhone
right?
first.
Before we move on to the next segment. We have people from Mexico, Santiago del Estero, Argentina. We have people from Chile, from the Dominican Republic, Uruguay, Tucumán, Bolivia, Guatemala. Wow. so many countries.
Pedro, did you mention Barbados?
Tenemos gente de Barbados, claro que sí.
Yeah, Barbados is in the house.
In the house, yes. And Chile?
Ken, listen to this. If we keep on doing things like we traditionally do you know how many? We have 20% of control. So we need to change our ways. This is one of the precepts over which we have to be based. Some people still say, no, 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 I'm fine with the system. But the system will not give you more than 20% of control. And when you don't
80% de su gente con la presión arterial.
go beyond that, that means that there's 80% that you are not covering, that you're not treating, and that you're not doing the right thing. So today's webinar has this following program. The things that we're going to teach here are the ways of doing things differently. And we will have three important communications. First, I think you mentioned this before. One is expanding team-based care with hearts.
That's critical.
This is one of the keys. If the program is still centered around the medical only and the doctors, this will not work. I'm sorry. Teamwork is key. Second, we have Hearts Pharmacy. We have a great team, very qualified, very energetic, very powerful. They have great communication with people. And how about we delve into these first
Tener el gusto de presentar al primer panel.
two segments? We will present the work based on team-based care. I have the honor of introducing Vilma Irasola. Vilma Irasola is well known in this region. She is a professor director of the Chronic Disease Center in the Institute of Clinical and Sanitary Effectivity of University of Buenos Aires in Argentina. She is a relentless fighter for cardiovascular health and leader. She's among the people who know most in the world about how a program is implemented and the science of implementation of a program. Vilma has been the mastermind of the results that we are presenting. So please, let's congratulate Vilma and her team and what they're going to show us today. She's a doctor, cardiologist. She is a woman. She is an investigator, and it's a great honor to have her here. And Vilma will be joined by two more people. One of them is Alicia Wellman, who is from Guatemala, doctor and researcher, also a woman leader in implementation of hearts in Guatemala with a lot of experience in ground research, and someone else who makes this that we learn from academics practical, right? Because sometimes we need to translate academics into practice. And that's the secret, right? Matias Villatoro, the coordinator of the program of NCDs and leader of Hearts in El Salvador. So without further ado, Ken will later receive the first rounds, but we give you the floor. Vilma Irasola, I give you the floor. Let's welcome her with a round of applause.
Thank you very much, Pedro. Thank you for your kind words, very generous as always. And thank you for the invitation, the possibility of taking part in this extremely important webinar today. It's great to be able to reflect together on this key initiative, which is Hearts. As you were saying, we have to do things differently if we want to have different results. And an important part of this doing things differently is without a doubt team-based care. In this review that we carried out with colleagues from across Latin America, a very prestigious group, and I would like to publicly thank them all. We have several results that we want to share with you. So if we click on this, we can see the rest of the slide. We talk about a collaborative model. We talk about a model that optimizes roles, that really professionalizes the knowledge of the different members of the healthcare team, especially as you were emphasizing, Pedro, the members of the healthcare team who aren't doctors. And so here we're talking about healthcare promoters, we're talking about pharmacists, we're talking about nutritionists, nurses. There's so many roles that we reviewed, and we have seen how important it is for them to work together in general, but in particular in the area of primary health care, where is that's the area that we see the majority of people with high blood pressure and other diseases and other chronic diseases. And there's a huge amount of evidence today about the effectiveness of working in as a team and the role of leadership of professionals who aren't doctors in terms of being able to improve the quality of care and also improving the results that we see in the health of the people who receive the care. And as you can see on the screen, we've carried out a great deal of work in the academic realm to be able to back up all of this with evidence and present this to the policymakers, the decision makers in our countries. And so we talk about the effectiveness of this strategy, and there's many more studies that I'm not showing here, but they do show, they prove the improvement in controlling high blood pressure, systolic and diastolic, with this team-based approach led by health professionals who are not doctors. But in particular, I would like to mention a study that was carried out by Chang Ji and other collaborators, and it was published at the end of 2023. And in this study that was carried out in China, and it included more than 34,000 hypertense patients. And it was a randomized control clinic in clusters. So there's a high level of scientific evidence that it produces. And in this randomized trial, we saw that hypertense people can continue to receive habitual treatment or an intervention led by community health workers. These workers were trained to be able to screen for and diagnose hypertension in the community. So this was extremely important because they were able to adjust their pharmacological treatment according to a standardized protocol, and this was supervised by the primary healthcare doctor. So this is the first pillar of the initiative, and we can see this in red in the graph. This in the first chart. We see how the people that were included in this randomized trial, you see the control group, and they received the normal care. And then in blue, we see the evolution of blood pressure in the people who were chosen randomly to receive this intervention. And so you can see that there's a significant reduction in the amount of people in the systolic blood pressure and the diastolic blood pressure of those who took part. So I would like to highlight the graph on the right, because up until now we had not been able to prove this as convincingly, but what we see is that it's not just that this approach improves the control of HTN and reduces blood pressure values, but it also reduces the incidence of heart attacks and strokes, heart failure, and other conditions that require hospitalization and that lead to death. And we know that this is the leading cause of cardiovascular death globally. So these are the hard facts related to high blood pressure. And we know that high blood pressure is the main leading factor that causes all the events mentioned above. So finally, I would also like to highlight that this beneficial effect of team-based care, which a team made up of professionals and community leaders and doctors, is an intervention that showed not only global results, but we also saw interesting results in the subgroups which were analyzed. We divided this into different categories according to the age of the person, their gender, their level of education, and the type of treatment that they received. And so my final message, as you can see on the screen, is that team-based care, which is based on teams, team-based care is not only an evidence-based, cost-effective strategy. There's no doubt about that today. But we're convinced it is the way to be able to reach an inclusive, equitable, and sustainable health system for all. Thank you very much. Thank you, Vilma. I think we should give her a round of applause. Are we able to do that? Thank you. There's lots of people that are thanking you, Vilma, and you've brought a very important issue to us. So I think it was really great what you said, and I think it'd be lovely to take a photo of the screen with all the hands that are applauding you, Vilma. There's lots of evidence. Of course, there are still people that would like to cast doubt on this, even famous publications that maybe people want to say that it hasn't been proven that team-based care reduces blood pressure, etc. But I think there's no doubt about it. We have the evidence, and we have to acknowledge something, Vilma. There is a great deal of resistance. I will give you the numbers to back this up later, but for now you have my word. What you're saying is that if we have a clinical pathway and a standardized treatment protocol, I want to leave that clear, and we have a team that have been trained up in order to deliver these services to the community, then that can be more effective than the traditional method of just going to see your doctor in the doctor's office where they take your blood pressure. And then it depends on whether people go for their appointments or not. So I'd like to come back to this point later with you, but what I want to highlight for now is that the issue isn't whether team-based care works or not. That's no longer the question. The question is, how can we dismantle this idea that is leading to resistance, that we're not moving forward on the correct path, and the people that question why we're doing that? So we're going to have to continue to work on that. We'll continue to talk about this in the webinar. But we're going to go to Matías Villatoro right now, who's the leader of the implementation of HEARTS in El Salvador. He's the coordinator of NCDs in the Ministry of Health in El Salvador. El Salvador is one of the most successful countries in implementing the country. It's one of 10 that has more than 80% of its health care centers that are implementing the program, more than 80%. So, Matías, we will ask you the first question. What strategies has El Salvador implemented to facilitate team-based work? Thank you very much, Pedro, for this opportunity. And I'd like to take the most of the opportunity to congratulate nurses today, because today is Nurses' Day. So we would like to extend a greeting to the population of El Salvador. So we follow the recommendations of the WHO, of PAHO, and we based our work on the clinical pathways. And we worked with nurses, we worked with health care promoters. We had people take part who were over 18 years of old. We also carried out home visits, and we also had these community doctors, that's what we call them in El Salvador. So we would work as a team, and we would try to create opportunities to accelerate this control process. And we would try to combat the inertia for receiving treatment and extend the healthcare coverage through these healthcare promoters so that they could take people's blood pressure and that they would be able to also give diagnoses. We also try to include a non-pharmacological treatment in this. As Vilma was saying, we believe that that's also important. And we believe that it was important that the nurses would be able to deliver, would they be able to actually prescribe these medicines. This is a very important challenge for us in our country. And it's in patients who are uncontrolled, this was a huge problem. So we had to work on this policy with the relevant ministries in order to implement good practices in terms of medical prescriptions and being able to, so that the nurses would be able to take part in this part of the process. So the use of fixed dose combinations and statins by doctors was something else that we had to work on. So this was very important, of course, because before the implementation of hearts, it was only doctors that could carry this out. Could you explain that to me again? Because this is so exciting and it's so important. So this is something that only rich countries do, supposedly. Sometimes we talk about the rich countries and the not so rich countries, and we have this difference. But what you're saying, if I understood you correctly, is that you got together a group of nurses, you trained them, you certified them, you taught them how to go through the clinical pathway, you use the standard protocol for treatment. And so now you have nurses who are trained up and certified based on this protocol to be able to give and prescribe the medication to patients? Or is it that the prescriptions are made by the doctors, and then the doctor is the person that diagnoses hypertension and who begins the treatment? But in your case, it's now the nurse that can start this process. Yes, that's correct. And El Salvador, there's a law that says that the only person that can prescribe medications is the doctor. So now the nurse receives the authorization through the minister so that they are able to be able to prescribe or hand over these medicines. So what happens when there's questions about the dose and they want to know if they have to take a tablet or half a tablet, half a pill? Well, that is a challenge because we receive a lot of resistance from the doctors. So we have to get the necessary authorization, and we have to support them technically and through regulations.
Okay. Ken?
Ken?
Yeah, no, I'm also on your wavelength, Pedro. I think that, but I want to get back to one point you mentioned, and that was what are some of the potential barriers to team-based care? And one such barrier is literally the absence of a standardized clinical pathway. A lot of the apprehension comes from especially non-physicians when there isn't a standardized pathway to follow, when they have to be guessing at which drugs to use and how to titrate them, when there is no coordinated care. And team-based care introduces two important things: task shifting and task sharing, right? Where nurses, for instance, may be involved in titrating up medication or advising patients on dietary changes required because they're living with hypertension. Where dietitians and nutritionists, and I know that we have a few of them on this call, Pedro, they have a role to play as well, not just in giving dietary information, but in counseling patients about the importance of taking their blood pressure, taking their medication, reporting side effects. Let me just say, and I just want to interrupt here, that one of the main barriers to team-based care in my country was actually physicians. I can say that as a physician, right? Because we saw it as taking away the kind of autonomy that physicians enjoy in the health setting, right? What training in hearts did, however, is that it certainly allowed us to see we are all on the same sheet. We all have the same, we should want the same outcome, and therefore there's nothing wrong in task sharing. I hate to drive this point home again, but this was even more critical during the pandemic when nurses who were traditionally assigned to NCD clinics had to be shifted for other things related, like swabbing or something like that. And so new nurses coming in, or even nursing students, nursing assistants, those kind of people coming into the health system at that time were able to follow the script. It's all about being able to follow the script. And I think that's so important. That has come out really in Matthias's presentation, comments here about the importance of team-based care. So congratulations to him. Do you want me to go on to, I have a question for Vilma. Do you want me to go on to that question now?
Vamos a ir primero con Alicia, ¿sí? Y después regresamos.
First, we will go with Alicia.
Okay, Alicia.
And then we will leave Vilma for the end, because we have Alicia Wellman, who is in Guatemala, in a very different situation. Alicia also has important expertise on how things are done over there. And the question is, from your experience, what are the benefits, the quantifiable hard data benefits of the team-based work approach in the control of hypertension and cardiovascular diseases and diabetes in Guatemala? Thank you. From my perspective, one of the main benefits that the work-based approach lies on the fact that it can adapt to the local context. First, primary care in our country constitutes many of nurse assistants, so involving them and training them is fundamental to increasing access to health in those historically ignored or neglected communities. We also are a very diverse country in Guatemala, linguistically speaking, and what comes of interest is that a lot of the nurses and nurse assistants are the ones who can speak those minority languages. So they are enhancing healthcare and also providing linguistically important care. So Alicia, do you notice a reluctance from doctors there too? Yeah, we also have some resistance here going on, but we're working on it. I think that the biggest workforce is integrated by the nurses, so integrating them makes task distribution.
Voy a hacer una pregunta. Esto está fuera de...
I want to ask you a question. This is off the script, but as we see that this systematically comes up, right? The issue of doctors. I don't know if Andres is here because Andres has an example that I love. Andres, please tell us, as a doctor who has worked in the ICU, right? You have some beds and some doctors there. And of course, if there weren't more nurses than doctors, the ICU and the coronary units would have to close, right? Because they simply wouldn't work. What happens when you have a severe patient in the coronary unit? What are the roles that the nurses and doctors have? Thank you, Pedro. I think we always say the same thing.
En equipo en el cuidado de la
The
hipertensión.
team-based work and treating hypertension and cardiovascular diseases is cultural in nature, and there's a lot of hypocrisy going on. The example is I worked 15 years in the ICU, where you have the most critically ill patients who often have 40 or 50% risk of dying within 30 days, and how we manage their glycemia with insulin pumps is a standardized intervention for these patients. And I've never seen a doctor doing a 24-hour shift standing watching the bed every minute. We have a table that has controls and numbers, and the nurses, who are the ones who do the more intensive care, are the ones who
De la
results
glucemia.
displayed of their blood sugar levels modify the insulin pump to administer more or less insulin to that patient and maintaining the levels stable. We're talking about incredibly sick patients who have at least 50% mortality rates within 30 days. We're talking about insulin, not just insulin, but also in many cases they administer IV noradrenaline, for example. I've had nurses doing complex procedures very well, and no one is scandalized by this because it's easy for the doctor because the doctor doesn't want to wake up at 3 o'clock in the morning, 3:30, 3:40, 3:50 to check that patient's level.
De pacientes
When
que
we're
tienen
talking about patients who have a 1, 2 mortality risk at every year, we're talking about managing antihypertension medications that are extremely safe and that would allow
una mayor autonomía de los profesionales no
for a greater autonomy of non-medical professionals.
de que este
I was
enfoque
saying today we do have evidence that this approach is not only superior to the doctor-based approach to hypertension, but it also reduces cardiovascular events and deaths. Very well. I brought Andres here in the discussion because in the chat, I see a lot of comments like, no, but nurses, that's not our job. Nurses have to do their own job and doctors.
¿Qué hemos hecho durante
That is true. That's what we've been doing. And you know how much we got? 20% of hypertension control. This is what we can get. If we don't have teamwork, there's no improvement possible. There's no improvement to quality possible. We cannot admit more patients into treatment. And then, Ken, I'm going to go back to you.
con
It's
Alicia,
very
con otra?
interactive. And then we'll go back to Alicia. But Ken, you are a pharmacist and clinician too. What level of safety do these medications have?
Yeah, and it's absolutely that reason why the evidence-based protocol is so important, because you have to have safe and effective drugs to be used. For that very reason, you may have non-physician prescribers or even dispensers, and therefore the drugs used have got to be safe. And the combinations used in hearts are, of course, evidence-based, but the drug safety profile is also there. So you have like calcium channel blockers, like amlodipine, for instance, as well as the angiotensin receptor blockers in combination. Now, these drugs, of course, like any other drugs, they have side effects as well, but pharmacologically, they work synergistically. And they also reduce each other's side effect profile as well, right? So therefore, combining drugs not only makes adherence better, but also reduces the side effect profile, and it reduces a barrier to care in terms of the non-physician, especially wanting to titrate up medication. And this is one big challenge we had in Barbados, for instance, not even with non-physicians, but even with junior doctors who were hesitant because, let's face it, there's so many drugs out there to treat hypertension. And Pedro, you said, we've been choosing from this menu, and I like big menus as well, right? But so many drugs, and we've gotten it wrong. What Hearts has done is simplified this into very evidence-based, safe, and effective drugs, and making it easy for what I like to call non-experts. Not everyone's a hypertension specialist. I know Dawn is on this call, but not everyone's a hypertension specialist, right? And some people need to, and the ones who are managing high blood pressure, most of the people are not going to be hypertension specialists. You need a safe and effective algorithm. Now, my final point on this is, what about the patient? Should the clinical pathway be simple enough so that even the patient understands what's happening? So the patient can say, okay, I kind of know my blood pressure is not on target. The next step is to take a full tablet as opposed to half a tablet. Even the patient has that knowledge. I see Alicia nodding your head here. So it's important that this also empowers not just non-physicians, but patients.
Bueno, esto es un debate sumamente rico, pero
Right, it's a very rich debate, but we're just taking our first steps. Look, we just finished a study at PAHO, and we asked a lot about innovations and steps moving forward. This is being a bit easier for people to understand, for example, people who have kidney disease, to then letting the team advance in some areas. So the cultural and political outpoint is very, very important. I want to tell you that the Medical Society of the South of the U.S. has convened a summit this year to talk about hypertension in November. Don De Petty is professor organizing this, and do you know what the theme is? Teamwork in the USA. Pay attention to where we're discussing this. We're not going to improve 40% if we don't change the rules. But I'll go through a last round before we go to Vilma in this exciting webinar. Matías, you have a lot of experience already. When
Y te preguntan cuáles son los
ministry with your authorities and they ask you which are the absolute benefits of having team-based work, how would you put it to a politician concretely and quickly, just as you would do it? Well, with data. With no data, we have no program and we can't move forward. So what we have is a evaluation and monitoring system that gives us like the temperature. And now that we're evaluating the quality of its implementation, we're seeing the results. More than 90% of nurse practitioners, that's 2,700 professionals and more than 2,700 health promoters are already certified in how to take blood pressure. And they are also training people over 18 to know how to register their own blood pressure. And this is an important practice because healthcare promoters are based on the community. So they have access to, schools, parents, communities, and they can get to these people that don't often get access. We have more than 74% of the population tested in healthcare centers. We've gone from 39% of control to 72.5% of patients with hypertension. Okay, we're going to repeat. We're going to repeat the numbers in slow motion. I want you to say it very, very slowly, what you've just said. We've gone from 39% of control of hypertension to 72.5% of patients under control. We've improved our population control by up to 16.5%. We had a level of 19.9% of control of population to 36.4% in a 4-year period. These are evident results, and we are verifying also that we have reverted the trend in mortality due to cardiovascular disease in our country, which is a very important landmark. Standardizing BP with standardized tension machines are crucial for good diagnosis. This is very, very inspiring, right? The results in El Salvador are important, and also in the transformation of the healthcare system. We're not saying here that in El Salvador a new drug was discovered. We're just saying the same medications that are being used rationally and intelligently and in a team-based approach. So, Alicia,
pasando en El Salvador.
when you hear this happening, what do you think?
Bueno, entre los principales, me gustaría empezar por los facilitadores.
So I would like to begin with the facilitators. First of all, I would like to highlight the deep level of knowledge that our nurse practitioners have, especially regarding the communities they work in. They're close to the people and they have a good relationship with them. And this means that the healthcare services reach those who most need it. Now, to respond to your question in terms of barriers, that's the high staff turnover. We have difficulty with continuity in the teams and teamwork. So I think other people have also mentioned, and I've seen this mentioned in the chat, but we have to point out the need to have clear rules that back up the skills of non-medical staff within this team-based care model. We need to guarantees that the service provided is appropriate and safe, and this applies not only to Guatemala, but to other countries. So thank you very much. We're going to give the floor to Vilma.
Yeah.
Vilma, we could be here all morning because this is such an exciting topic. We are waiting for the pharmacists because these are one of the people that are involved in this teamwork. Vilma, go ahead.
¿Sí? Bueno, creo que ahí
Okay.
Ken, ¿sí? Bueno, no hay problema. Sí, go ahead.
Great.
Go ahead. Okay, go.
All right. Okay. So Vilma, so I want to take you back to Argentina. Can you highlight, you've given a lot of evidence about team-based care in your presentation, but can you elaborate a bit more about the experience in Argentina?
Gracias, muchas gracias, Kenneth. Sí,
Thank you very much. Yes, we have carried out lots of different studies in Argentina in order to back up this evidence for team-based care. And it's very clear that in terms of controlling high blood pressure, in reducing high blood pressure, and in ensuring adherence to the medication, this is a very key point. Working with the community and working with the professionals that work in people's homes. In our country, we have generated a lot of evidence on this, and I know that this is the case for other countries in the region. And I think, as has been said several times, that the political will, clear norms and rules facilitate professionals to carry out their job in a safe manner. That's fundamental. And another issue that I wanted to mention is this issue of training. Not only training of our current professionals, but to be able to implement this work from the medical schools when people are being trained to be healthcare professionals. We don't receive that at the moment. And I think that it would be great to have that as a starting point. So as we're being trained in our professions, we should be able to work from a team-based care perspective.
That's so important.
Thank you very much, Ken.
Yeah.
So we're going to be speaking about this issue when we talk to the pharmacists because they're a key pillar of teamwork. But I'd like to congratulate Vilma, Matias, and Alicia. And I'd also like to congratulate the teams that worked with them on their paper, on their research paper. Somebody has published, or could somebody help me out and publish the link in the chat? There we go.
It's already there.
So this is a political framework. It's a policy framework. One of the things that I'm discovering, now we have 1,300 people, and we have space for more. So use your social networks, invite more people to come and join us on this webinar and see what's happening, see what's going on. Post this on LinkedIn. There are people who are taking pictures of the session and they're posting it on LinkedIn. So by doing that, you help us because this is an issue of awareness. We need to raise awareness of this team-based care. So Vilma, Alicia, Matias, and I could mention the rest of your team. We are hugely proud of all of you and the work that you're doing. It's very inspiring for all of us. So we're going to have an active pause right now.
Yep.
And then we're going to talk to the pharmacists. So let's go with our active pause.
Bueno, qué alegría para continuar nuestro webinar.
Great. Well, let's keep going with our webinar.
Sure.
We're going to go on to the second section. So we were going to call this Heart Pharmacy, but Ken, I'm going to give you the opportunity to introduce our main speaker for this session of Heart Pharmacy.
I am so
You have the
excited to
floor,
do so,
Ken.
Pedro. You know I've been waiting for this part of the program for the entire morning, right? So Emily Ridley, she's a clinical pharmacist with Prisma Health in Columbia, South Carolina, in the United States. And she has worked for over 25 years within the internal medicine clinic and provides care as a provider for patients. She's a clinical instructor of internal medicine. So I know how challenging that can be. I show some empathy, Emily, for the University of South Carolina School of Medicine, Department of Internal Medicine, and she's also an adjunct assistant professor for the University of South Carolina College of Pharmacy. Emily, I know we've met several times, but it's especially great to welcome you to this webinar, and I look forward to your presentation.
Thank you so much, Ken. I appreciate that. I am so very honored to be here today and excited to share with you about our paper Hearts Pharmacy, which was just published in the Pan American Journal of Public Health. Our paper specifically addresses the role of pharmacists in hypertension management within the primary healthcare setting. You'll be able to see the QR code for the paper on the slide shortly, and please scan it to get the link, read it, and share it with your colleagues. This paper was a collaborative effort of 15 different authors from diverse backgrounds and different countries, all with the same goal of integrating pharmacists into primary health care to aid in filling the gaps of access and quality. We focused in this paper on the significant evidence that supports the pharmacist's role in hypertension management, as well as identifying the barriers to integrating them into clinical care, and also recommending key actions to move forward and drive change. As you know, Hearts in the Americas has many terrific modules that help in guiding its implementation, including access to essential medicines and team-based care, just two of them, and having the Hearts clinical pathway outlines straightforward steps for improving patient outcomes in the primary healthcare setting with easy-to-follow algorithm, as we've talked about. Some of the key areas we focus on this paper are the roles of national pharmacy systems, community pharmacies, and community pharmacists in advancing care. Of course, access to quality evidence-based medicine that fit within the WHO guidelines is crucial. You'll see on the slide that truly the strengths or skills that the community pharmacist brings to primary healthcare are invaluable. This figure from the paper lists some of these key strengths and skills. There are many, as you can see, but I'd like to highlight the medication management expertise, the skills in patient education and counseling, easy accessibility and approachability of the pharmacist, as well as the availability for that routine blood pressure screening and monitoring. Seems that the pharmacist is perfectly positioned to help fill both the access gap in primary healthcare as well as the quality gap. Now, the big question is, how do we move forward? What actions do we take? So the paper outlines these points, which you can read, of course, further, but advocating policy change is important. Institutionalizing the Hearts clinical pathway and having that algorithm is very important as well. Promoting that task shifting and team-based care models that we've been talking about are integral. Emphasizing the pharmacist's expertise in medication management and understanding these medications, side effects, drug-drug interactions, and things like that. Enhancing the pharmacist's role in patient education and adherence, really at the forefront of being able to communicate with these patients at the point of even getting medications and knowing that they're filling their medications or not and helping addressing that. Empowering the pharmacist to conduct routine blood pressure monitoring, strengthening those national pharmacy systems, and improving the community pharmacy infrastructure and training. We also include some successful case studies that you may find helpful. And I am thankful that we have two other authors from the paper here as well who shared case studies and can offer their own unique insight. We had phenomenal group of authors, and I want to thank them so much for their contributions to this. This was tremendous all across Americas. We are really excited about the opportunity for further pharmacist involvement in helping improve hypertension control and truly reduce cardiovascular risk.
So thank you, Emily. And this is phenomenal. I mean, I especially liked your emphasizing the farm.
No, go ahead. ¿Sí? ¿Te quedaste sin sonido, Ken?
Creo que se pausó. Ajá.
Ok, entonces, no, yo retomo aquí, así que Ken y yo estamos haciendo una pareja aquí.
Okay, so I'll take over because me and team Ken have been hosting this session. It is amazing what you are saying. There's a part of your paper that I particularly like. When you looked at the evidence, of pharmacists' role in improving blood control and diabetes and cardiovascular diseases, one piece of evidence was when you asked members of the community, who is the health professional that you most trust? Who are you closest to? What did they respond to you when you asked that question? Please tell us, Emily.
The pharmacist.
Y puedes desarrollar un poquito más esa idea.
And could you tell us a little bit more about this? Why? Why is it that the pharmacist is such a key collaborator? Why does the community believe in them so much?
I've always thought of the pharmacist as kind of the interpreter between sometimes their provider and the patient, being able to speak both those languages, being able to share that information in a way that's understood by the patient, language that the patient understands, and very approachable. Often, physicians are so well respected for many reasons, but sometimes patients are afraid to ask questions, but they're not afraid to ask questions to their pharmacist. And the pharmacist sees maybe that they're not filling their prescriptions and can say, is there a problem? Are you having a problem affording your medication? Are you concerned about side effects? Is there something that we can help you with? So I think, the pharmacist is trusted because of the information that they know and the information that they can share and help the patient with.
Saben comunicarse bien y tienen mucha información y
They know
conocen.
how to communicate well. They have a lot of information. They have a lot of knowledge. So people trust them when they ask them about their medication. They ask them, can I take this medication? Can I mix it? Can I combine it with another one? Should I take a half a dose? Should I take the full dose, etc.? And so this is the potential that the pharmacists have. We should look at the pharmacy not just as a place that dispenses medicine, but rather a place where patients can be educated, where they can have their blood pressure measured, where they can become an active part of the health system, right? So we're not currently making the most of these resources. So we have somebody on our panel called Stephanie. She's a clinical pharmacist. Stephanie Geisel. She's a clinical pharmacist and a postdoctoral fellow at the University of Alberta. She's very well known in Canada. And we're very, very proud to have her with us today. She specializes in cardiovascular health and hypertension management. So, Stephanie, we have a question for you. We know that pharmacists have significant knowledge on medication. They're highly trained. This applies to different countries and different places. So how can this education and training that pharmacists have, especially in Alberta, Canada, how has this changed the way in which the pharmacist takes on new roles in the clinical management of patients. Welcome, and over to you.
Thank you. So in Alberta, which is more on Western Canada, for anyone who's not familiar, we have one of the most unique scopes of practice for pharmacists globally. So pharmacists who are in good standing can apply for what's called your additional prescribing authorization, which allows you to independently prescribe any Schedule I drug, except obviously narcotics and controlled substances. Any pharmacist who has completed a year of full-time experience in direct patient care or who graduated from a Canadian PharmD program after 2018 can apply for this. In terms of education and training, pharmacists in the PharmD programs in Canada are trained to complete limited physical assessments, order and interpret blood work, create comprehensive care plans with patients. We also receive additional training in collaborative care, which also occurs in the other health faculties such as medicine and nursing. So we all learn to play well with each other. To prescribe, pharmacists must present patient cases to our regulating body from their practice that demonstrate that they have the necessary knowledge, skills, and clinical judgment to be able to prescribe. In addition, pharmacists must have strong collaborative relationships with other health professionals and practice supports in place that include access to blood work for patients and being able to document in a medical record. And what's interesting is the standards for pharmacist prescribing in Alberta are the same for physicians and heavily emphasize the assessment of the patient. We are trained that prescribing is simply a tool, but the assessment of the patient is the key.
Muy bien, Stephanie. Y profundizando en
Excellent, Stephanie. And thinking about this role of the pharmacist, what are the practical changes that you are making to prepare the pharmacist to be able to take on these new roles? Do they have to, how do you do it? Is it happening at university? Is it happening through pharmaceutical associations? Because it's not enough just to say it. We have to really bring about change. We have to be responsible in this, respectful in this. We have to implement a systemic change, an institutional change, a cultural change. So how are you doing this, Stephanie?
Absolutely. So this happens kind of in two different places. Our pharmacy training in the faculties has changed to incorporate more of the patient assessment piece. And then to set pharmacists up for success, if they're already in practice, there does need to be a program or aspects of training that involve didactic learning and clinical experience. There should be accessible online programs to gain further clinical knowledge that review pathophysiology of disease, perhaps more in depth than what they learned in school originally, therapeutic management, but also assisting pharmacists to gain confidence in patient assessment by reviewing the common lab investigations and the basics of physical assessment techniques. In addition, there should be clinical experience programs. So pharmacists should either shadow other pharmacists who might have a clinical role, or if this is not available, shadow other healthcare professionals such as physicians or nurses to gain that real-world experience and collaborative care. So in Canada, there's programs for practicing pharmacists already through the different universities, as well as this is heavily incorporated in the initial PharmD programs now. And I really think within PAHO, countries should share their successes to help guide pharmacist education, whether they're already practicing or they're currently in school, to confidently be able to provide patient assessments and engage in prescribing.
Pedro, I'm back, and I also I got here just at the right time. My internet is being attacked by beta blockers, it would seem, right now in the university. But I really wanted to drive home the point about training and how you have shifted training of pharmacists to incorporate these team-based elements. I mean, I'm in medical education. It's not easy changing curricula, right? How have you managed to do this successfully? Because it's important for the longevity of team-based care.
There was definitely a ton of resistance at the beginning, more so from the medical doctors. But
You can say,
uh-huh. But it really has been a very large shift amongst all the professions. And I think having the different faculties on board, whether it's medicine, dentistry, nursing, physio, everyone has to be on board and engage in team-based care for other professionals to succeed and expand their scope of practice.
definitely. And collaboration with PAHO is critical even with academies, right? I know, for instance,
Absolutely.
the University of West Indies, we have a strong collaboration with PAHO, and that was really how we got the parts package incorporated into our training of medical students and hopefully soon also pharmacists and our nursing staff. So thanks so much. I really appreciated those comments, especially from an education standpoint. And Pedro, should I move on now to Carolina?
Sí, podemos hacer lo siguiente. ¿Qué?
Of course, we can do this. Ken, you know how intense and interesting it gets, right? These types of reflections. We currently don't talk about this enough, but before we move on to Carolina, I'd like to make a comment. You know that one of the main complaints that we get in every country, and some of them I don't want to mention because, you know,
Right.
political delicacy, but when you see a doctor in certain countries, means waiting months for an appointment. I don't know how this works in Canada or South Carolina or Barbados, but in some countries it takes months. And if you want a cardiologist, 6 months. Endocrinologist, another
Or
6
more.
months. I don't need a
There you
cardiologist to
go.
see me after 6 months, right? It's a no-brainer. So we have a lot of resources, and we're still rejecting these to help these people participate actively in their healthcare. We maintain the status quo without making any changes. So if we have skilled nurses and pharmacists and other professions, of course, we need to do what Stephanie was saying. We need to go to colleges. We need to go to universities. You that are the dean, the university has to be training the professionals who have the
Absolutely.
necessary skills required by the system. And sometimes there's a divorce between curricula and what health services actually need. So as long as we keep on with the divorce and the division, and we stifle universities from having skilled professionals, we will not change. So I think this is it's high time that we pay attention to this social demand. Of course, we can bridge the gap, right? The bureaucracy is one of the biggest barriers of mankind, the biggest man-made barrier to medicine. We have doctors
Definitely.
sitting on a throne for decades, and of course we can change this. Chronic diseases are seen throughout a person's life. When a person crosses a line and has hypertension, they will have hypertension for their whole life. When they have a chronic disease, they will have that chronic disease for as long as they live. So what, are we going to treat it with fragmentary one-off consultations? No. And now we have Chile, the champion. I'm very proud because the person who I'm going to introduce you to now, Carolina Neira, is a nurse. But when she says she's a nurse, she says it in capital letters. I am a nurse
She's a
with
super
great
nurse.
pride. I'm a nurse, and I am the director of non-communicable diseases of the Ministry of Health of Chile, one of the biggest development countries in our hemisphere in healthcare, and she is the director of chronic diseases. What does this mean? I leave it to you, so you ask her directly. Ken.
Great, sure. So thanks, Pedro. And I also wanted to add, it's so important for people in academia to have our hand on the pulse and to be involved in health systems so that we can also respond to the current needs of the health system and not just in an ivory tower kind of, the academic environments sometimes can be very sterile. So Carolina, so your experience in Chile was highlighted through a case study focusing on the legal and regulatory changes to allow pharmacists to be involved in intensifying treatment. And I can really identify with this in Barbados. What were the first steps in this process? Could you just walk us through that?
Hola, muy buenos días a todos.
Hello, good morning, everyone. Greetings to all Chileans joining here. I know we have a lot of them, and all of Latin America and the Caribbean. I'm very proud to have been invited here. Before I give you the answer to this question, and looking at the previous speakers' presentations, a multidisciplinary team-based healthcare is based on each person. We see the person's needs at the time they come to us. We do not let go of that person with cardiovascular risk, and we give that person what they need in that moment. It is a continual, safe, and quality healthcare, and that, as a team, treating non-communicably diseased people, we usually see people who have multiple comorbidities, and we need to focus on them, and the team is crucial. The multidisciplinary team is crucial. And the story of the chemical pharmaceutical professionals here in Chile is not recent. They have been working in primary care since 2014, when the ministry program of the pharmacy fund was created, and then they gave them certain components, such as the pharmaceutical healthcare. This is a type of healthcare that supports the multidisciplinary work that has taken quite a learning curve, that also tackles the pharmacovigilance. Their training here is robust in Chile, and we are working from universities on how to include components of direct healthcare, like how to take blood pressure, and the intensification of care under a standardized protocol, another asset to their pharmacotherapeutical care. They see beyond all that, all social determinants, and the person-based approach is the one that they usually implement.
Right.
In 2022, we moved on with nurses and also with chemists and pharmaceuticals, and we read them our law, and we told the juridical department of the health department that according to the current law, if the chemist can intensify under standardized protocol, according to that do that, and we had enough support from the law to actually perform this job here in Chile. It wasn't an overnight journey, but we were convinced that multidisciplinary work is the spearhead to arrive at better indicators. Right now, we're working legal support, then we're working on pharmaceuticals being convinced, and they are convinced already, and they're really eager to start working on this, because they often do. Our next step is that the information system
permita esta intensificación según protocolo estandarizado, porque actualmente el sistema solo permite que esto lo haga médico y no permite
now in Chile works and allows for this intensification according to standardized protocol, because currently our system only allows for this to a doctor.
Right.
And it's been a week since our norm maintenance has come out that will integrate the nurses and the chemists' pharmaceuticals. Wow, Ken, this is great progress.
It's
Think
amazing,
of
Pedro.
Philly. When I give an example of a country, I do it wholeheartedly, because if there is a country that has had a calling to primary healthcare, a country that has given guaranteed that their citizens will get quality healthcare, if there is a country committed to medicine and to improving its medicine, then if they can do it, we can also do it. I think we need to study this
Absolutely.
case and not remain with our arms crossed,
Mhm.
because people die of cardiovascular diseases. Let's remember the numbers. People are dying. Do you know how many people die of cardiovascular disease every day in this region? 1,000 people per day. 6,000 people. Think of it as next to a plane crash or next to the death due to COVID. We're talking
Yeah.
about 6,000
hacemos las cosas correctas.
cold feet. The problem is no longer if this works or not, Emily, and your paper.
¿Verdad? No es que el paper que acaba de publicar Vilma con su equipo no
The
está
paper that Vilma recently published is not questioning if the team-based approach works or not. The question is, when will we start implementing this? Now I want to look at the chat. Let's do a little exercise. I'll give you two chances. We will evaluate how capable your country is today in teamwork, not only of nurse and pharmacist.
Mhm.
Someone was telling me, Pedro, we have rehab workers and nutritionists who are angry because you're not mentioning them. I'm talking about a whole team. Nutritionists, of course, have a role to play. Healthcare workers in general, I've seen in Argentina the communities doing community work, trained on how to go to remote neighborhoods and take people's blood pressure. I've seen it in Guatemala and in Salvador. People who are getting trained, but I wanted to see the chat. Please, this is a prompt. We'll give you from 1 to 3.
con el
My
trabajo.
country is not very committed to teamwork. 2 is my country is kind of committed.
Vamos a poner mi
And 3 is my country is fully committed to teamwork.
Si ponen el país,
1,
mejor.
2, or 3, and if you add the country, all the better. Let's see, 3, 3, 2, 3. Okay.
Okay,
What else?
interesting.
Uh-huh. Okay. Well, okay, let's stop the exercise now.
Vamos a hacer la segunda pregunta, interactiva
Second
también.
question, interactive, right? After listening to these fantastic talks with these fantastic professionals, the question is when I, let's say I'm Pedro, but Emily's Emily and Stephanie, Carolina. When I leave this webinar, I'll be more or less committed to supporting teamwork. 1, not committed. You've not convinced me. 2, yeah, you've more or less told me the same thing I always hear. And 3, yes.
Comenzamos, yo voy a mirar.
1, 2, or 3. Okay. 3, 3, 3, 3, 3, 3. Is it true? I don't see any ones. Okay. 3, 3, 3, 3, 3. Oh, okay. Okay.
Very.
Big round of applause for the team. Please leave your hearts, your claps for these professionals. Please do not leave. I want a final family photo. We will
Con otra cosa que
minute break. Something else to motivate us to go to the last segment. We got to do all this. Yeah, we don't have policies. Forget it. So in the third segment, we'll have Esteban Mondoñez, who I'll present soon to paint us the picture. All right. I'd like to snap a picture, right? It's great. People supporting Carolina and Stephanie and Emily. You see, you have the papers there. Please read them, publish them, share them. PAHO makes free papers. It's one of the few institutions that has open access, free papers, so anyone can access them. You need to use them, right? So we're going to go to a little pause. Yeah, production, pause in 3, 2, 1.
¿Audio? Está como la comedia silente. ¿Audio?
We're not hearing the audio on our end.
Okay, well, audio, please. Bueno, esto sin audio es un poco aburrido, pero intentemos entender, ¿sí? Que estamos hablando de la calculadora de riesgo cardiovascular. La buena noticia que tenemos aquí con la calculadora de riesgo cardiovascular, Ken, es que no es tan importante.
So, in terms of this cardiovascular risk, the important thing is that this assessment, the evaluation of this risk doesn't paralyze us, but that it helps us to realize that a certain patient who has a certain condition cannot receive the same treatment as a person who is not high risk. We have to prioritize high risks. We have to give the correct dosages of medications. Unfortunately, we didn't have audio on the video, but we are going to move on to talk with Esteban Londoño.
Yes.
He's a Colombian physician. He's our captain in terms of managing everything that's related to quality in hearts. And hearts is something, quality is something that is an element that's learned, that's taught. And Esteban Londoño has a doctorate in public health. He's a physician. He has a master's in public health as well. He's one of the key leaders in our team for Hearts in the Americas. So it's with great pleasure, Esteban, that I give you the floor for this last section of our webinar. Thank you very much. It's an honor to speak representing the Regional Hearts team. And I'd like to greet all of the colleagues that work in primary healthcare, especially those that work in different ministries across the region and that are working on this issue day by day. So we're going to talk about this hearts quality issue. And basically, we're going to talk about two things to close this webinar. So the hearts framework, the hearts quality framework, and the methodology for improving quality in the Americas. So the first thing to note is that Hearts has been implemented in 2017. So we've been doing this for 8 years. It's a young program which has achieved great results, but it's a program that also faces a lot of challenges. And this Hearts quality framework methodology allows us to tackle these challenges more quickly because we need to save lives urgently and quickly through this program. So in terms of this quality framework, here I want to remind you that this is based on the technical package put together by the World Health Organization 2016. And this technical package is very important because it's a strategic focus to improve the approach to tackle cardiovascular diseases in healthcare. So Hearts is no longer just a technical program. It is now a continual improvement of quality because it has evolved conceptually and methodologically. So this technical package is what we built upon, but we have evolved. And there are lots of publications on this, but I'll highlight two, which are very important, which are like the drivers for the control of hypertension and cardiovascular risk in primary healthcare. And we have another paper which identifies Hearts as a transformative program in healthcare systems. So through these transformative drivers in healthcare, we are not able to do this if we do not work with healthcare systems as Hearts. And another very important thing is this tool, which brings together 8 drivers, including 17 interventions for bringing about improvements based on guidelines by the WHO to control high blood pressure in adults. So as our colleagues would say, this has brought us to a point of more maturity in our positioning as hearts in the Americas. And this quality framework brings together these drivers. It brings together the best available evidence about how to drive transformation through a program in healthcare systems. So we need to have a quality framework so that we can comply with the relevant norms and standards. So what is our mission? To strengthen primary care so that we can control hypertension and reduce the risk of cardiovascular, kidney, and other metabolic risks. So here we see that we have this standard of care in PHC, and our quality framework is made up of 11 programmatic strategies. We're going to whiz through them, and then we'll do a quick exercise with the countries that are represented. So first of all, we have 8 interventions. 3 of them are structural, and 5 of them have to do with the process. So thinking about the structural aspect, we have to think about effective governance in our countries. In order to implement this, we have to have effective governance at a national and also provincial and local level. That's essential for having good leadership in hearts. And we also have to have regulatory frameworks that will allow us to have monitors and devices that are validated and automated. And as Pedro and Kent has said, we need to have effective medication available in primary health care. So these are the key variables at the structural level. And then we have 5 strategies that have to do with the process. And as my colleagues have already said, this highlights the importance of team-based care, of multidisciplinary and interdisciplinary care. But this team needs to be trained up, and we can use the clinical pathway, which should be institutionalized. It's not enough for this clinical pathway just to be hung up nicely on a wall. It has to be something that's institutionalized and truly included in the processes and procedures of these institutions working on primary healthcare. We need to carry out accurate measurements. We need to be able to classify cardiovascular risk and offer the best treatment possible, as well as offering effective follow-up and to be able to guarantee adherence. So these are the 8 conditions, the 5 elements of the process, and then we have some results from the populational point of view. So HEARTS is a program that contributes to the strengthening of healthcare systems in terms of managing hypertension in the population. So going back to cardiovascular diseases, so we have 3 variables in terms of success. So the first is that we want to reach more than 80% across the primary healthcare network in our countries. And we have 33 countries that have committed to this, but only 10 have achieved it. So the invitation is that we would all continue to work towards this goal so that we could reach that 80% of adherence in these primary healthcare networks. And so the diagnosis, sadly, in Latin America for hypertension is 3 out of 10. But in the world, that's almost half of the population has hypertension. So we need to improve this diagnostic process and treatment. We need to be able to improve the level of hypertension in our populations. So we have So we want to go from 36% in America, Latin America and the Caribbean to 50%. Pedro told us about this before. And in 3 to 5 years, we would like to save 400,000 lives and avoid 2.5 million events that lead to death. So this is our commitment to save lives and avoid suffering. And finally, we're going to close. Sorry to interrupt you there, Esteban. But could you just go back to the previous slide? I'd like you to help us to really communicate this message well. It is not enough to make political declarations, to issue communications make statements. We have tons of these meetings about policies. We need to move on to action. We need to go from commitment to action. And the quality programs try to move away from this passive contemplation to actually evaluating in solid terms what it is that we're doing. Concretely, what is it that we're doing? Is that what you were talking about, Esteban? We want to see this, we want to go to move on to implementation. We want to institutionalize these clinical pathways. We want to make sure that healthcare authorities take responsibility for this and that they help make available the necessary resources to be included in and to have these blood pressure monitors available, as well as high quality medicine to manage hypertension. We are not talking in Hearts about lowering quality. We are talking about improving the quality of services in an equitable fashion, because we see that those who receive the worst quality of care are the poorest people, because they're more vulnerable, because they don't have access to medications, because they don't have the adequate blood pressure monitors. And so we are talking about a quality program which is also inclusive and equitable. So now I'm going to hand over to Ken so that he can talk about how we can implement this and how we can implement it well. Yes, but there's something very important here. We have moved forward in terms of universal health care coverage, but in the UN system and PAHO, we haven't had sufficient access with quality. We've had empty promises, but we are offering access to quality. So it is complex, but we don't want to be paralyzed by this. The good thing is that we have this quality framework, which is a quality methodology that we have carried out. And so we have made it easy for you to use it. This is our invitation to you. It's being used in 11 we have 11 strategies that are designed to facilitate these evaluations within your own healthcare systems. That's the objective of Hearts. And so the good news is that these strategies are not only based on the best possible evidence, but they're also based on experience of the best health systems, such as the health system in Canada, who have really managed to control hypertension, or also with this Kaiser program in the United States. There's also great programs in Chile and the Dominican Republic, in El Salvador and Cuba, etc. So we have a lot of success stories.
We want to thank all of these countries that are based on scientific knowledge. We have universities, we have a lot of healthcare workers in all the territories of the countries of the Americas. We have Belize, the country that greeted us first. We want to thank them for the quality that characterizes them and of their training program. We were in El Salvador, Mexico, Suriname last year, and this year we were already in Mexico and Cuba. We have been invited to go to Trinidad and Tobago and relaunch the implementation of Hearts there. We're going to go to Guyana in August and Chile in October. So we want to invite you to keep on with the ripple effect of this training to improve the quality in all of our countries. And we're announcing that we will very soon have this new virtual course, because, we cannot physically go to every country of every region, but we will seize this opportunity with this course that's focused on continuous quality improvement for primary healthcare teams. Remember that Heart is focused on strengthening the skills of healthcare professionals in the benefit of the population. We don't want Hearts to be just a protocol. we're not talking about the HEARTS protocol. HEARTS is a comprehensive program, and we want our healthcare professionals to understand the clinical and the managerial and administrative tools that they need. This will be a self-administered program that has 5 modules. The first one will be led by Dr. Ordóñez, which is the why should we implement HEARTS. Then we have what there is to implement, what are the key drivers and interventions for quality improvement. Module 3 and 4 will delve into how we can implement this. Module 3 focuses on essential clinical tools. Dr. Rosende will focus on how we can actually apply all of these essential clinical tools. And then in the 4th module, we'll delve into the quality improvement methodology, that is how we use the planning model to actually act and learn. And in the last module, we will have Dr. Rodriguez, who will explain the implementation and evaluation framework of HEARTS in the Americas. We want to invite you all to click on the links in the chat. These are very important publications because they present the evaluation framework for continuous quality, and they also summarize technical elements that we have on essential clinical tools, the methodology. And remember, we are inviting May to be the month in which we evaluate our progress and how we are tracking hypertension. We want to get an overall assessment of this. Very well, Esteban. Ken, I want to propose another one of these massive exercises. Excellent, excellent. That was exactly what we needed to see. You called people's attention on this. Your communication, as always, is very good. Those of you in the chat, please help us. We have thousands of people, and we have just one very brief communication from the director of PAHO, who will address all of us today on World Hypertension Day. So,
Wow.
save a few minutes for the director, who will be here in a minute. The director of PAHO will broadcast a message for our World Hypertension Day, but before that, we will do a chat exercise. There are a lot of people in this chat, and people from Cuba are telling us, hey, don't you see us? We're here. There's like 20 of us sitting in the PAHO offices in Cuba watching this webinar, but let's do the exercise. Write the name of the countries or cities that are here, 2 minutes, and say hello to the colleagues.
Lots of people from Mexico. Mhm.
Wow, US, Mexico, Panama, Venezuela, Chile. A lot of Caribbean countries too. We invite all panelists to turn on their cameras. Wow, fantastic. I hope you watch the recording and share it, please, with your colleagues. To all panelists, please, family photo time. Well, anyone who wishes to be in the family photo, you look
We like
very, very
photos.
handsome. You can, we have more people than this. Oh, it's a shame that we cannot fit everyone in the photo, but you're the main protagonists. Those of you backstage also. We're waiting for the director's message. Let's see what he has to tell us about World Hypertension Day. Mariana, let's snap a picture. Arancha has also been helping us. We have a 1,300
You all ready
people
now?
webinar.
Oh, we've got the message.
Oh, we have the director. Okay. Wow, we have a picture with the director. Let's snap the picture now. 1, 2. We send greetings to Emily and Matías. Okay. Elibardo, Andrés. We're all here, yeah. Okay. So we have a picture with the director of PAHO. Send us a heart, like, whatever. You're the one who's techie. Kenneth, before we give the floor to the director of PAHO, Kenneth.
Yeah, so Pedro, I wanted to just add that what I took away from this fantastic webinar are 3 main points that we need to address to get past the barriers to team-based care. And tell me what you think. So one is, it needs to be evidence-based, and we do have the evidence. You've posted it in the links, all of the various clinical studies, everything. So the evidence needs to be there. Secondly, training. Stephanie said it has to start from the schools and universities and colleges. How do we train the future generation of healthcare providers? How do we train the current generation so that everyone is attuned to team-based care? What it means, respecting each other's individual skills, but working together as a team. And finally, which is really what Esteban just covered, is the quality assurance. We need to make sure that we're getting things right, we're recording the correct metrics, and that our program and team-based care especially is really having the impact that it should. So these are my 3 things: evidence, training, and the quality assurance measurement.
Excelente, Ken. Entonces, sin más.
Excellent, Ken. Without further ado, we will give the floor to the director, Gerardo Barbosa, who's going to address us. We're extremely honored to have the chance to hear from him. All countries who are implementing this program and who are participating in this webinar are delighted. We have lots of representation from other countries such as Jamaica and many other countries that aren't actually implementing the HEARTS program, so from the United States as well. So we're really pleased that we have Australia implementing HEARTS in the northeast part of Australia. And it's also being carried out in Alberta in Canada, which is to say that this model is expanding across the world. And it's going to be wonderful over the next few days to see how this is developing. So without further ado, I give the floor to the director of PAHO. Hypertension, or high blood pressure, is a common condition that, if left untreated, can be fatal. It is also the main risk factor for cardiovascular diseases, which claim more than 2.2 million lives each year in the region of the Americas. That's equivalent to 6,000 deaths per day. This is unacceptable because it is preventable. We can all reduce our risk of hypertension by staying active and maintaining a healthy weight, eating fresh and nutritious foods, and reducing our salt intake, especially hidden salt in packaged and ultra-processed foods. Policymakers have a key role to play by implementing policies that promote physical activity and healthy eating, such as salt reduction and front-of-package food labeling. But prevention alone is not enough. In the region, up to 4 in 10 adults have hypertension, and 1/3 of them don't know it. Among those who do, only 8 out of 10 receive treatment, and of those, only 6 out of 10 have it under control. That's why it's important to seek medical care. Get your blood pressure checked, and if diagnosed with hypertension, take medication to control it. We must provide better care, and we can. Treatment is simple, safe, and affordable. PAHO is leading the implementation of HEARTS in the Americas, an initiative that uses simple treatment protocols, team-paced care, and strong monitoring systems. 33 countries have committed to implementing this initiative, and 10 are already applying it nationwide. In 7,200 primary healthcare centres, better care is being delivered to millions of people, but many more still need access. We've made great progress, but we must strengthen primary healthcare so that everyone receives quality care, no matter where they live. HEARTS works. It's the best strategy to reduce preventable deaths from cardiovascular diseases and to strengthen primary healthcare. With HEARTS, countries can advance towards the 80-80-80 goal for diagnosis, treatment, and control of hypertension, and prevent more than 400,000 deaths and 24 million heart attacks and strokes in the region. On this World Hypertension Day, let's make hypertension control a top priority. Check your blood pressure accurately, control it, and live longer. I think that's an excellent way to end. The director has, it would seem he's been listening to us because he summarized exactly what we've been speaking about. So that was really inspiring. I hope it has been for all of you. And for those of you that haven't yet decided to do it, for those of you that aren't doing it yet, and even for those of you like those in the Dominican Republic that are implementing the program so well and even received an award for it, as we found out today, I hope that this webinar has been an incentive to all of us to be able to make a difference. It's not fair that people die for something that we are able to control. It's not fair for them to die prematurely, but we have to be aware that hypertension is the main cause of cardiovascular disease and of heart failure, of diabetes complications, of renal insufficiency, of kidney disease. There are so many complications, so we need to be aware of this. And I would invite my co-moderator to close. Ken, you have the floor.
So, Pedro, this has been so much fun hosting this with you. But it hasn't just been fun, it's been an important message. We really do need to get out there that we have the tools that we need to really attack the NCDs and hypertension. World Hypertension Day really just can't be another soundbite. Let's go out there and just do better. We have the tools. We have the instruments in HEARTS. We have the monitoring framework. We need to get together to address those barriers that we discuss and get going with team-based care. I just want to say a big congratulations to the HEARTS team. I feel part of the HEARTS team as well on HEARTS Pharmacy. This is a tremendous achievement. And all the pharmacists on this call and all the non-physicians, I don't want to forget the physiotherapists, the nurses, the nutrition dietitians. You know, when you think about it, the pharmacist is the last person the patient sees at a consultation encounter, after he's seen the doctor, after he's seen the nurse. You know, the last person seeing the patient is usually the pharmacist. You have such an important role to play. Thanks for all that you do, and get on to HEARTS Pharmacy. There's a lot out there. I'm looking forward to how this package advances.
Bueno, muchísimas gracias y nos vemos pronto en el...
Thank you very much. We'll see you soon in the next webinar. Thank you very much to all the speakers. Thank you to the 1,300 people who joined us today. And hopefully we will be able to upload this webinar and English and Spanish on YouTube in the coming days. It's such a shame that we have so many healthcare centers that weren't able to participate in today's meeting. So that's why I really do ask you to share this with your colleagues. We need to get this message out there with all the people that are able to make a difference. Thank you very much. I hope you have a great day. Goodbye.
Here, bye.